Hello, my dear friends. Pavel Krastev, DDS. I welcome you today from sunny California, Los Angeles, to be more specific. Anyhow, so we came here for the holidays, and it's going to be today's a rather special day because this is the last Padinar of the year, and we have a very special guest that's going to teach us about zygo implants. And that's certainly a very hot topic these days. Certainly a topic that interests me very much. And I look forward to learning about it because I myself have to admit that I know very, very little about this rather exciting and revolutionary concept that everyone seems to be curious about. So on behalf of myself and Global Summits and Dr. Keanu Shah, we welcome all of you. It's a pleasure to host you from Los Angeles, California, as I said. And let's bring Dr. Simon O in the field here and say hello. Let's introduce him. Hello, Dr. Simon, and welcome, my friend. It's a pleasure to meet you finally. And I'm very impressed with the beautiful, beautiful work that you do. And, we have a nice day. And today, as I mentioned earlier, is a special day because actually we had a fantastic year. Thanks to all of you guys, of course, and all of our colleagues and all of the entire organization, the Dream Team, the Regents, the Board of Directors, and of course, as always, most importantly, our audience and our colleagues. So I'm going to wish you guys a very early Happy New Year because I won't see you again here, and wish you the best in 2021. And I'm sure we'll have a better year altogether collectively. And together, as always, in dentistry and healthcare in general, will revolutionize getting closer with each other and being stronger together. So, ladies and gentlemen, I want to introduce again Dr. Simon O. He's from Pennsylvania, and we're having some rather technical issues today. So I'm using a cell phone, a computer screen, another screen. So I'm going to read Dr. Simon's resume right now a little bit here, and then I'm going to turn the podium over to him in order to share his wisdom and his knowledge in the theater of zygo implants. All right, folks? So put my reading glasses on and read this to you. So Dr. Simon O. grew up in Maryland, where he received his Bachelor's of Science in the University of Maryland, College Park in Physiology and Neurobiology. He then graduated with honors at the University of Maryland Dental School, where he achieved the highest national board scores in his class. He was a member of several honor societies, including the OKU Honor Society for academic and clinical achievement. Dr. O was also the lead guitar player of his band, Incidental. Whoa. Finishing his dental education, Dr. O furthered his training and trained extensively in inpatient, outpatient, in conditions from impacted wisdom teeth and dental implants to major facial reconstructive surgery. So Dr. O is extensively trained in implantology, ladies and gentlemen. Dr. O is also a published author in the Journal of Maxillofacial Trauma. One moment, so I scroll down. Excuse me, guys. Well, I lost my spot. One moment. So today, Dr. O serves as Chief Clinical Officer and Chief of Implantology of ProSmile, the region's largest DSO, overlooking clinical operations of over 200 dentists and dental specialists throughout 79 locations. My God, that's crazy. That's impressive. You have to explain that to us. Sure. As a fellow in the International Congress of Oral Implantologists, Dr. O has special interest in dental implant surgery, the All-on-X full mouth reconstruction concept, zygomatic implants, teeth in a day, and bone regeneration. With Dr. O's unique skill set, acquired from training around the world, he leaves no patient behind, even if they have no bone. That's fantastic. In addition to being voted by his fellow dentists as top dentist in Philadelphia Magazine in 2019 and 2020, Dr. O has also been selected is one of our top 40 dentists under 40 in the United States by Incisor Edge magazine in 2020 for his clinical skills, involvement in education, and leadership in the field of dentistry. That's impressive, bro. Let me just scroll down again. Doctoral lectures, mentors, and trains doctors nationally and internationally on implant surgery on a regular basis for many different implant companies. He focuses in delivering the highest quality empathetic care to his patients in the most pain-free manner possible. Dr. Roy enjoys traveling, golf, and spending time with his wife, Sophie, son, Cameron, daughter, Claire, and their two dogs, Max and Mandy. Man, that's a very impressive resume. And you gotta tell me a few things. First, what kind of dogs do you have? Because we love dogs.
They're two hound mixes. They're both rescues from the South. I think they came from Georgia. And one of them has pretty severe prognathism. He's got a really bad underbite. The actual origin of the name of the two dogs, so Max and Mandy, short for maxilla and mandible, actually.
Oh,
if you will. So the vet's always going to chuckle whenever I go to the vet.
Tell us a little bit about what motivated you to pursue dentistry as a career, and tell us just a little bit about yourself. Anything you'd like to share with the audience would be appreciated.
Yeah, sure. So I guess the main reason that I became attracted to dentistry was because the dentist that I had growing up was great. He was always very attentive to patient care. He always, focused on achieving the best clinical results, and he was just a really good guy. And so that, sort of opened the door and got me interested. And so when time came to entertain medical school or dental school, I gravitated towards dentistry, and that's really the beginning of the whole story.
Fantastic. And now the next big question, and by the way, I probably mentioned this, but let me say it again. I'm going to meet with Dr. Shah here. And I'm very excited because on Monday, we're going to go visit him, and we're going to have some important things to discuss. But regardless, I spoke to him yesterday, and I said, Dr. Simon has 70-something offices. And Dr. Shah said to me, really? So did I correct? Are you managing, or tell us a little bit about this huge success and exactly what you do?
Sure. So I can't take credit for the whole thing. I have very good partners. So about 8 years ago, I met Dr. Amish Patel, who's a dear friend of mine now. And he and his father always had the vision of group practices, to sort of gain leverage back from the supply companies, the insurance companies, et cetera, and bring it back towards the clinician. And so from there, Dr. Patel and I and our good friend Bharat Rana, we took over a small 8-office organization in New Jersey. And then from there, we just started to grow. We picked up some really great partners along the way. And, we are the size that, where we are because of good relationships amongst each other. So.
That's fantastic. Congratulations on that. And that's a whole other topic of discussion, how to grow to that degree. That's impressive. So guys, let's turn the floor to Dr. Simon, and let's watch this wonderful presentation, and then at the end we'll take some questions for those of you who have any. And please, Dr. Rowe, go ahead and share with us your wisdom.
All right, thank you. Okay. All right, guys. Well, thank you for having me, Pavel and Kianar. This is an awesome opportunity to be able to, speak on a platform this large. It's very impressive how big you guys have managed to grow this thing as well. So today I'm going to be talking about zygomatic implants. It's something that I'm very passionate about, just because it really was the last piece of the puzzle of my full arch practice. I practice 4 days a week in a full arch practice, and we tackle up to roughly 300 cases a year. And this really was a game changer for me, and just brought loads of confidence. So, just having that ability to tell a patient that they're going to leave with teeth, like almost a guarantee, is just so crucial. You don't have to have those difficult discussions anymore. So that's what today's going to be about. Non-conventional implants. We'll touch a little bit on the pterygoid implants and the nasalis implants, but here on the title page, you can see the actual CT scan of a zygomatic implant. It extends into the cheekbone. And what is this implant? It's, this came about by Dr. Brannemark in the late 1990s, and it was, I'm guessing, out of pure frustration of not being able to work with the atrophic maxilla and trying to find distal remote sites of anchorage with good bone. And if you look at the human skull, you look at all the areas that have dense bone. So they're the areas that get hit the most, where patients have trauma. So for instance, the chin is obviously we know is D1 bone. The glabella, or the frontal sinus area, is D1 bone. The nose and the cheekbone. And so, Dr. Brannemark, along with a lot of other guys, pioneered this concept, and it is what it is today now. One thing to touch upon is that oftentimes a zygomatic implant is looked at as terminal treatment, in that it's the last ace up a clinician's sleeve to get them teeth. All right, what are some indications? So generally speaking, it's just either not having enough bone or the bone quality is poor. So if you have an atrophic maxilla, you'll have a poor AP spread with conventional implants. And, as we all know, cantilevers are going out of fashion, especially with the introduction of zygomatic and pterygoid implants. Another indication is poor medial sinus wall anatomy or pneumatization. You can also have poor bone quality. So if you look at a CT scan and you see not very white areas in the posterior maxilla, you may want to consider having a conversation with the patient about zygomatic implants, preoperatively. There's also cases, as we've all seen, where there's absolutely nothing. And in those circumstances, we need multiple zygomatic implants. Another indication is also after some sort of resection of the maxilla. So as you can see, AP spread is a very important topic, especially in the maxilla. And so one of the rules of thumb is, you want to have, or at least you used to want to have, 2 times a cantilever versus AP spread. But I think that a lot of people are getting away from that, especially with these zygomatic implants, where you can basically float a prosthetic platform in the first molar area. And here's Brannemark's medial sinus classifications. You can see that over time, or with disease, you get atrophy of this good bone area that you can use for conventional implants. All right, so I want to touch upon the difference between natural maxillary atrophy and what I call iatrogenic. So natural maxillary atrophy, we know long-term edentulosum or long-term denture wear. You typically see buccal bone resorption in the maxilla and a pseudo class 3 skeletal relationship. And here's an example of one where this is the exact mid-sagittal line of a maxilla. And you can see that, this patient probably was in class 1 before, but with all the buccal bone resorption, now we're in pseudo class 3. Now, here's an example of what I call iatrogenic maxillary atrophy. And I think that in the coming years, we're going to see a large uptick in this type of atrophy. Even though the bone is present today, it doesn't mean that it's going to be there later, especially if you have failing implants that need to come out. So this is a case that I inherited with one of the acquisitions that we had in New Jersey, and we had several implants placed, but sort of haphazardly, and the patient went home with a denture. Now, a lot of times that may sound good, but the problem is that with continued wear of a denture, you're going to get buccal bone loss. And over the course of a year, I'm sure that the surgeon placed these things nicely, but today, this is what it looked like. You could see the entire apex of that implant. And so with a case like this, without immediate loading, we're going to see a lot of these kind of cases where after we take out these implants, we're not going to have much left. So in this case, we had to take everything out because everything was failing. And then this is, what we had to end up doing. So you can see here, there's 2 implants into the piriform rim, or to the nasal floor. You have 2 zygomatic implants, 1 on each side, and then 2 pterygoid implants. In a patient like this, this is the last stage that we could do it. This is it. After this, there's not much more that we can do. So it's important, with a lot of dentists getting into implants these days, I'd suggest that, especially if you have a patient that wants an implant but also has other failing dentition, to consider, circumstances like this where, if we place implants all over the place and we have to remove them later, we're going to have to resort to more invasive treatment. Here's another case of what I call iatrogenic atrophy. So you can see 4 incisors restored with 4 separate dental implants. That's not exactly ideal, and the 2 on each side are actually touching. And so after something like this, there's not much left, and again, we have to do zygomatic implants. Luckily, we have that tool up, in our practice, and so we can provide these patients with these with a very solid arch of implants. But ultimately, if we can avoid doing these kind of cases, it's better for the patient. So we started with this, and then we had to use every trick of the book, which is transsinus or transnasal zygomatic and pterygoid implants. Here's another case. Again, many failing implants into a sort of radical approach. Here's another one. This patient actually came from Pavel's neck of the woods, drove down from Brooklyn, but you can see again, 4 incisors replaced with 4 separate implants, and we have failing numbers 9 and 10. And so after this came out, there's really nothing left underneath of that, in between the nasal floor and the alveolus. So we placed 2 zygomatic implants on the left, 1 on the right, and a vomer in the middle. And here's a case of a unilateral. So that's iatrogenic atrophy. Now, in terms of zygomatic implants, what are some contraindications? It's all the same as conventional implants, except for 2 things. One is a history of sinusitis with the need of an intrasinus zygomatic implant, and also not having enough bone. So here's an example of a zygoma with an abundance of bone. This is like your dream patient, especially if you're getting started in this. But sometimes there's not enough. In this case, this would be a case where I would call up Rami Sieve of Norris Medical to see if I can get an easy goma case with him. And this is probably what you're looking at in terms of average. The implants that I place are Norris Medical, and the diameters typically are 4.2 millimeters. And so in respect to biology, we need at least 6 millimeters or so of thickness. All right, here is the classification system of zygomatic implants. So you have, this was described by Carlos Aparicio. So it's 0, 1, 2, 3, and 4. And basically the only difference is it depends on the anatomy of the patient, so, and the concavity of the maxilla. So if you see Zaga 0, you can see that it's a rather flat profile of the zygoma, but when you get over to Zaga 4, you see a pretty exaggerated concavity there. And that's really the only difference. So here's an example of a Zaga 0 completely in the sinus. You actually open a lateral window to place this thing. And this is how actually zygomatic implants were always placed when they were first done. And the problem with that is that, with containing an implant completely in the sinus, if you look at Zyga 3 or so, you're going to end up very palatal. And so prostheses early on with zygomatic implants looked like this. And here's an example of one being removed, and you can see how far off it is from the hybrid that's in place. So now with the advent of what's called an extra-maxillary approach, we can get our implant platforms basically wherever we want. And the best place to put them is right through the teeth. All right, here's a diagram of a zygoma. So this was described by Rigalizzo. And basically, it gives you different zones of the zygoma and the best places to place your implants. Generally speaking, you want to place your implant, if it's a distal implant, as low as possible so that you can maintain a rescue space. And I'll show you what I mean in a minute. And here's from the Hung article from Jomi. Again, different zones of placement. All right, so in terms of vital structures, you have the orbit and globe, and those are two different things. Just because you enter into the orbit doesn't mean that you're going to hit the globe. The infraorbital nerve, the MSA, the infratemporal fossa contents, and the facial nerve, so the zygomatic and temporal branches. So you can see, based off of the human skull, the zygoma bone is relatively close to the eye, but as you can see, it hangs pretty low in some areas, and that's really where you want to place it to avoid any of those really nasty complications. And when you do your dissection, you will encounter the infratemporal or the infraorbital nerve, just like you do with the mental nerve when you're doing a lower. And the MSA is often encountered with cases like sinus grafting, but you can see that it's also applicable for zygomatic implants. And the contents of the infratemporal fossa. The internal maxillary artery is not something you want to play with. All right, here is the facial nerve. So this is a topic that really I don't think has been discussed very much, but it is one that worries me just because, paralysis after having an implant placed is probably the worst thing that can happen to you. And when you place these implants, you can see that it's just one layer over. So the facial nerve, the temporal branch, is right behind the periosteum of the zygomatic arch. And so when you place these implants, there's largely two ways to do it. One is to dissect all the way up to the notch, and I'll show you where the retractor goes. But I know a lot of people who actually place these things without dissecting up there, and that sort of makes me nervous. But the results are good, so I can't really argue. Now here's a guide that I invented. I have a patent pending on it, and this actually tells you exactly where the implant will exit the zygoma before doing your osteotomy.
We did the osteotomy yet, but we know exactly where it's going to come out.
That's great.
Yeah. Made the osteotomy.
All right, the extra-maxillary technique. So it's a little bit different. You have to sort of change gears in terms of what you normally think about implants, which is, it has to be fully encased in bone. You can't have any thread exposure. You have to have 1.8 millimeters of a bone all around the implant. But it's actually different with this because the implant actually hangs out in space. It most of the time lays on top of the maxilla or on the outside of it and extends down into the alveolus. As a general rule of thumb, you want at least 15 millimeters of bone implant contact. And ideally, you'd like to have the implant resting on the maxilla, just so that when your patients bite down into food, the wall of the maxilla can actually help resist the flexion of the implant. The osteotomy is through and through, so you get bicortical engagement. And that's important because these implants can span up to 60 millimeters. And so you don't want to have a small amount of bone anchorage when you have a 60mm implant. So here are some examples of the extra-maxillary technique. As you can see, the implant rests on top of the maxilla and extends down into the alveolus. And it's great because you can really just float an implant platform where there is no bone. A lot of these patients have really poor medial sinus wall anatomy, and so there's no way to get an implant there unless you go transsinus, but that has complications in itself. But in this case, you have a platform basically wherever you want it to be. Here's what the Norris kit looks like. You can see and appreciate how long the drills are. And again, these things range from 30 to 60mm. So there's a wide range, and it's much longer than your conventional. All right. In terms of anesthesia, because the zygoma is curved, you can't go completely all the way up with an intraoral approach. So you actually have to give anesthesia outside the face. And what I normally do is I do a zygoma infiltration. I'll do a V2 block with Marcaine, infraorbital block, and PSA block. So here's the ganglion of the maxillary nerve and the pterygopalatine ganglion, and that's the target of your V2 block. So this is my incision. This is how I've been trained, and this is just how I do it from day to day. I know a lot of other people have their own flap designs, but this is what works for me. I do a crestal. I always go back to the tuberosity, which this red line doesn't show, but I also do roughly like a 1.5 centimeter vertical on the posterior aspect of the buttress. Here's what it looks like. And this is what I was talking about with the retractor. So this is actually where it ends up going, because you need to visualize all this stuff. And if you have a drill playing around in a space that you don't know where it is, it very well could tangle up with the facial nerve. At least I think it could. I don't think there are any actual bits of data that have been documented, but it's just something that, if you can avoid that risk, I think you should. And intraorally, this is your view of the zygoma. And this is a case that we did. And so when you open it up like this, this is really what you're dealing with. So you can see the upper curve is where the eye is, or the orbit. The dot is the infraorbital nerve, and then the lower curve is actually the start of the infratemporal fossa. This white arrow actually shows where the insertion of the master tendon starts from the zygomatic arch. So you do encounter that, and oftentimes you have to clear out some of that tendon in order to place your implant in the ideal position. So this blue line sort of tells you, you want to stay nice and low. And so you can see the area in between the two curves leaves you plenty of room for a second implant if you need to do it. So even if you're only intending to place one, always place your one as if you have to place two. Now here's a case of mine earlier on without respect of that concept. As you can see, there's plenty of bone underneath of where this implant is going, but early on I was not nervous, but cautious, and so I wanted to make sure I got a good outcome for the patient, and so I placed it where I knew I could get bone. But with more and more experience, I figured out that placing it lower is very possible and very reliable. Here's a more recent case. So if you look at the patient's left side, you can see how nice and low it is, but on the right, it's actually nice and high. Now, the reason why I did that was because first I attempted to go low, but there wasn't enough torque. And so we had to use what's called the rescue space. And so if you look at how white the area is where the implant apex is, that's density of bone. And so that right there is almost always consistently thick in a patient's zygoma. which is right lateral to the eye. It's a little bit more dangerous, but it's a very reliable position if you can't get torque low. All right, so with the Norris system, again, it's just so intuitive. It makes so much sense to do it this way. So first you mark your drill, which is where your implant is going to enter the zygoma. From there, you have to actually visualize and imagine where your implant platform is going to be. So the way that I do it is I get line of sight with the patient and the zygoma and the alveolus. I picture a circle so that if you imagine your implant, if you line it up perfectly, all you see is a circle. And you want to be able to predict where that's going to be in the alveolus in respect to the zygoma. And from there, that's where you mark. So you can see here, sometimes I mark a few times just to make sure I get it right. And we ended up actually placing the implant lower down than our original mark. Now, this burr here is revolutionary. Rami C really thought this through and did a great job with it. What it does is actually cuts a channel into the alveolus so that your implant can sit nicely on it. A lot of the other systems are different. You have to basically take a gigantic round burr that's like 40 millimeters long and cut through the alveolus with that, and then go up to the level of the zygoma. This is sort of backwards, but in a good way. And so after you mark, you use this non-end cutting burr. As you can see, it's machined. You place it into that mark, and then you lower this thing into the alveolus. Now, it's important that you don't go too far into the alveolus because you could end up with an implant that's too shallow in the zygoma. And you also don't want to do too little because you could end up with your implant into the infratemporal fossa. Checking, double checking, triple checking at this stage is really important. And once you've got your line of sight and you have your trajectory down, that's where the guide that I invented comes into play, because the most dangerous part of this placement is the next step, which is the osteotomy. So this is actually my partner, Alex Benner, placing his implant. And so because this implant is through and through, it's important that you keep your retractor close to the zygoma, because once you enter through it, you'll feel a vibration against the retractor, and that's when you know when to stop. If you go too far, you're just going to widen your osteotomy, especially at the apex, and it could compromise your torque. All right, now there he's through and through. Next step is to probe and find out how long your implant is going to be. So you go through, pull it back along the buckle. So you can see in this picture, you measure based off the buckle, because this posterior distal osteotomy site is not flat. It's angled, and so you could get two different readings if you lean this thing against in this view, the inferior portion. It's going to read much longer than if you hold it against the buckle. Now, this is what it looks like in the mouth. You can see it's all the way through. Then you pull it back along the buckle. Now here's the hand driver to place this. Some people use a handpiece, which is fine. For me, I like this just because I feel like I have full control over it. So you can see the Norse implant is machined all the way up to the apex, or the apical 15 millimeters or so, so that you limit the amount of bacterial adherence that you end up getting versus other implant companies. As you can see, it's not fully in bone, and so there's really no advantage to having a treated surface the whole way through. And another thing to note is that with this hand driver, it's actually very deceptive. You can, it may not feel like very much torque, but even with slight wrist movements that don't feel too tight, you're at 100 newtons before you know it. So ideal is placement of this upper implant, not the bottom implant. So if you look at the upper implant, the apex is just barely peeking through the osteotomy. You want it to be like that because these things that you can actually palpate outside of the face if you go too far. So that's why it's very important to base your measurement off of the buccal shortest aspect of the osteotomy. And this here is not ideal. You don't want to have thread exposure. So after you do your osteotomy, this is what it typically looks like. Again, you can appreciate that you now have a prosthetic platform in an area that probably wasn't doable with the conventional implant. And from there, there are two different types of zygomatic implants. So one is this type where you have the platform open, but there are some one-piece implants out there. The Straumann one, the Southern brand. Now, it has its advantages in that it's one less potential bacterial leakage source. But the problem is that if the platform is already, if the angle correction is already built into the implant, what if it torques out too high? You're going to end up, and you can't end up turning the implant anymore, which does happen with these types of implants. Then, you're sort of guessing that the prosthetic platform could be upside down. And then from there, you have to amputate it if you can't restore it. So that's why I appreciate this design, because these, especially when you're dealing with D1 bone, anything can happen. So from there, you take your angle correction again. I think it's crucial to have up to 60 degrees in multi-unit abutments. That way you can restore these things. Because this is not this is far different from conventional all on 4, all on X. All right, so here's the end of the case. And now here's a circumstance with an absent premaxilla. So sometimes we have to place more than one. And this actually was a patient of mine that I'd like to show everyone, just so that you can potentially avoid this treatment course. So, I spoke to the patient about doing zygomatic implants just based off of how atrophic her maxilla was. She did not want to do it at all. And so we attempted to go traditional. So, how do you do that? You stuff the sinuses with bone, you place implants back there, and you pray that the body absorbs it and actually turns it into vital bone. But in this case, that wasn't the case. Every implant except for one failed. There was bone in there, but it wasn't vital. And so there was no osseointegration. After that, we did a round of BMP grafting to try to bulk up the ridge and try to regrow with PTFE membranes. And we got good results, or at least results that we can expect. We got bone volume, but unfortunately, the quality of bone was really poor. And so from there, this is 2 years in the making. This patient has been in a denture the whole time. That's been uncomfortable, and was just honestly miserable. And so from there, she said, "Okay, I'm ready to do zygomatic implants." So after this, there's no premaxilla, so we had to do multiple on each side. So this is the left side and the right side. And the beauty of this is that it's done in one day. And so we ended a miserable 2-year journey of bone grafting with 4 simple zygomatic implants, and she walked out with teeth. Now here's another case. Again, iatrogenic maxillary atrophy. This patient had some sort of on X in a different state, but you can see that all of them are failing. You have thread exposures all over the place, some that aren't even being used because they're not restorable. So, when we took her to surgery, I told her, there's probably not going to be any bone or not enough to only place conventionals. So I prepped her for 2 conventionals, 2 pterygoids, and 2 zygomatic implants. But after we took everything off, I placed 3 implants in the front just to over-engineer, but none of them torqued. And so that at that point, especially with a patient like this who had refractory depression and couldn't tolerate a removable denture, needed immediate loading, we had that trick up our sleeve. So, we placed 2 on each side. But as you can see, the AP spread of this case isn't very good. You're going to have a large anterior cantilever because there's nothing in the anterior, and then there's also going to be a cantilever in the back. And so in a case like this, this was a really tough one. And so we ended up placing 2 pterygoids in the back because we had that real estate, and we got a good outcome. Again, with the patient, you can see that there is bone there, and had the clinician not used every bit of bone possible, we could have gone with something way less invasive. Had this been in my hands a couple years ago, it would have been a traditional case, but it is what it is, and we got a good outcome. And here's her prosthesis. So you can see there is some anterior cantilever, but it's not too bad. But overall, we got excellent AP spread. Here's our X-ray. And here's a case that I did most recently. This was last week. Again, a patient, natural maxillary atrophy. So she's been in a complete denture for decades. Since she was a teenager, and she's in her 60s now. Here's her pano. All right, so those are all the success stories. There are some complications. Just like any other implant, they are prone, or not prone, but they are subject to failure. But luckily, the success rate, if done right, is right where conventional implants are. Upper 90s. You could also have dehiscence of alveolar mucosa. You could have sinusitis, penetration of the orbit, like we talked about, injury of the infratemporal fossa contents. You could have fistulas form both inside the mouth and outside of the face. So this is a case of mine, actually. So this patient, we did a nice piriform zygote-pterygoid maxilla, but she had recurrent swelling over the course of the month. So a week on, she was on antibiotics for 1 week post-operatively. But after that, she swelled up on the left side. After that, we put her back on antibiotics, went away. As soon as that ended, again, it swelled up again. So at 1 month, we took a scan, and you can see that there's bone loss around the apex. You can see the darkness, the dark halo around the apex there. So we simply just took the prosthesis off, took the multi-unit off, and reverse torqued it. And there was granulation tissue at the end of it. Here's an example of alveolar mucosa dehiscence. So you can start to see the collar of the implant. Sometimes it's a lot more exaggerated. And this is why, again, if you're going to do extra-maxillary implants or zygomatic implants, a polished collar is so much more beneficial than having a treated surface. just imagine how much plaque would be built up on a treated surface there. And again, this isn't my case, but this, you can see how the implant in figure B is violating the orbit. And again, like I said, the orbit and globe are two different things. The globe itself is actually pretty far from the outside of the orbit. There's lots of fat and muscles in there. But in this case, the patient actually had restricted extraocular movements. So just like with the trapdoor fracture of a orbital floor fracture, this could also impinge a rectus muscle. And here's a case of obviously going into the eye. Not ideal. And here's this case from 2010 was documented. I don't remember where, but basically a clinician used a zygomatic implant in the pterygoid region, which you should never do, because zygomatic implants, the shortest that they go is 30 millimeters. And if you look at the studies, the pterygoid implants are typically 15 to 18 millimeters long. If you're up in the 25 range, which I've done before carefully, you actually are getting pretty close to some pretty vital structures. And in this case, with the zygomatic implant in the pterygoid region, 30 millimeters or more, this actually penetrated the skull. So, this patient had recurrent headaches, didn't know why, and so they took a scan and realized that the apex was actually inside of the skull. This is another complication, so oral antral fistula. This is my patient. So, we closed everything up great. I guess post-operatively, maybe he blew his nose when he knew he shouldn't. But regardless, fistulas form, and they can form, especially if they're intrasinus implants. And so it's just duly important to maintain the Schneiderian membrane if possible, and also get a really good closure. But these cases do arise. And so this patient was complaining of air communication through the mouth and nose on the right side. So we took the prosthesis off and saw a pretty significant fistula. So in a case like this, you do your fistulectomy cut. I sutured this portion together and pushed it up to reform a Schneiderian membrane, or a sinus membrane. From there, you can see, how big this thing is. It was probably like an inch by an inch of an opening, a bony defect. So, we pulled out the buccal fat. We placed a bio-exclude membrane, and luckily we got closure. And here's an example of a cutaneous fistula. Luckily for me, I haven't had any issues with this yet. If you do enough of anything, you're gonna have every complication. But again, I think that the patient that I showed where I removed the implant, had I left it in there, this almost certainly would have formed. All right, well, that's what I have for you guys. Pavel, if you want to start a Q&A session, I'm happy to answer whatever questions. Thanks for listening.
I think Dr. Pavel will be joining us shortly. He might be having some technical issues. Yeah.
Okay. Well, there's a couple of questions on the side I guess I can answer in the meantime.
Yeah, sure.
So one of the questions was, how do you manage the complications of a zygoma implant? Do you have possibility of replacing a failed one? And yeah, so there's, like I was saying before, the rescue space. If you look at the zygoma, you want to place your implant down in this region. That way you leave all this good space available if you need it. And so I've had, in my career, 2 failed zygomatic implants that we had to replace or remove. And so if you place it down here, you have all this real estate to place a new one, and you can do it the same day. You don't have to wait. If you place your implant straight through, you know, I can't imagine, I mean, you probably could place one, but, you know, with a little bit more risk because you'd have to go further back up into this area. But yeah, so there's most of the time room for 2. Let's see. Don't you think that the zygomatic implants in some cases have been inserted too much in the center of the zygomatic bone? Yes, absolutely. So I've seen a lot of cases, and myself too. Early on, I was certainly placing them not in ideal positions. And with conversations with a lot of great clinicians out there, I refined my craft. And so almost all of my implants go down here now, and are in the 32.5 to 45 millimeter range. My implants before, when I was first starting, a lot of times ended up in the 50s. But as I honed in on you know, trying to perfect this procedure, I've been placing a lot shorter ones. There's a question in a different language I can't understand. I'm sorry. It looks like French. All right, Amit Shah, since the zygomatic implants are long, around 60 millimeters, but bone implant contact is around 15, wouldn't we have leverage issues when retained in fixed prosthesis? That's a great question. So one of the complaints of a quad zygomatic patient is a diving board effect when you chew. So if you look at these implants on a model and you put light pressure on it, you'll see them bobbing up and down. And so you can imagine the strong mastication forces from your master muscle biting into something. The patients do feel a diving board effect. And that actually brings up another good topic, because when you place a configuration with just 2 conventional implants in the front and then 1 zygomatic on each side and nothing else, you see the conventional implants in the front fail first. Because you have flexion of the posterior, but none of the front. And so the front takes a beating because actually there's a lot more pressure than a conventional all-on-4 case. So that's a great question. Do you do it in medically compromised patients like me, controlled diabetic? So I'll place these implants in a controlled diabetic. My rule, based off of, and there's not much basis, but just based off of reading a lot of different articles about diabetes and implants, 8.5 is generally my cutoff. Just based off of all the little bits of information that I've come across. Another question is about using guided surgery. So the only guide that I would trust at this point would be the Zygoma guide from Norris, because it's a bone. It's a titanium guide, which is ultra rigid, but it's also screwed onto the bone, and so there's very little room for error. I've seen a few cases, like I think Chrome guide has some sort of solution, but it's all intrasinus. And I've also seen a few solutions with plastic, but you know, with implants this long, the slightest change in trajectory at the alveolar level will change things dramatically. So I wouldn't trust anything other than the Zygoma guide. Okay.
Yeah, I think that's all the questions we have, Dr. Simon. So if there will be more questions, you will see this on the Facebook chat, and you can answer them there. There's another question that has just come up. Could you
please clarify more about Zyga? Yeah, so Zyga is, I think it stands for Zygomatic Anatomically Guided something. It's what it basically is it's very simple. It's prosthetically driven, so the given is that the platform of the implant is going to be ideal. It's not going to be based off of where bone is, where good anatomy is. It's based off of where the proper prosthetic platform is supposed to be. From there, dependent on the anatomy of the patient. So if you look at this skull, for example, you can see how concave this is. This is going to be a Zyga 4 because you're going to have trajectory from here to there, and you're going to have space in between the implant and the bone itself. But if this were less concave, say that this was more like that, like a flat one, that would be a Zyga 0. Because again, you have to fulfill the two criteria, which is enough bone at the apex for your implant and also the prosthetic platform. So that's really it. And they're just different varying degrees of concavity. And it goes from 0 to 4. What about irradiated patients with atrophic maxillary? I don't think I would do anything like this in an irradiated patient, especially over the recommended dosage. Yeah, I would steer clear of that, just because if you have, I don't think there are any documented cases of osteonecrosis of the jaw in the zygoma level, but I can't imagine what that would be like. Since placing zygomatic implants requires special skill and experience, wouldn't direct sinus lift in placing axial implants? I don't really understand the question, but I think what you probably meant was, is that an alternative to placing these kind of implants? And the answer is yeah. But, with, like I was saying before, with delayed loading, you have all sorts of complications because these patients need teeth to go out. And so what do you have? A removable denture that's going to beat up the buccal plate. And maybe not so much in the posterior with the sinus lift, but in the anterior, you have implants that are going to be subjected to pressure on the buccal plate. And you're going to see cases where, all the threads are exposed, just like the one that I showed. So is it an option? Of course it is. And that's sort of what I walked through with that one case. And I wanted to emphasize that sometimes the conservative route is not the appropriate one. I took that patient through 2 years of grafting and pain and multiple surgeries with no results. We ended up doing the quad zygomatic anyway. So if we'd done that from the get-go, we would have saved her, 2 years of pain and suffering. So, all right. Well, I think that's it. Thank you, everybody, for having me. Thank you, Kionor and Pavel. I know he's having technical difficulties, but I'm honored to be here and very grateful to be able to speak to everybody.